Hi everyone, this is your PowerPoint voiceover on the treatments for coronary artery disease. We're going to talk specifically about cardiac catheterization and some medications. In someone with coronary artery disease, cardiac cath is the most definitive, but it is also invasive. In diagnosing CAD, if someone is suspected to have myocardial ischemia, we want to look at exactly which vessels might be blocking some of those areas. We use radio-opaque material or dye. We inject it through the groin or radial site to see the flow of the dye through some of the vessels. You might have heard the term cardiac cath plus or minus PCI, left heart cath versus right heart cath. The left heart cath, you usually insert the catheter up the aorta, aortic valve, and into the left ventricles. The right heart cath, which is usually actually done first, inserts the catheter through either the inferior or superior vena cava, through the right atrium, right ventricle, and both of those you also look at some of the pressures as well. And once you do the heart cath, the physician can determine the best option, whether they need an intervention such as stents, or if there's multi-vessel disease, they might need a CABG or coronary artery bypass graft. Some of you may have had the opportunity in clinicals to take care of a patient going down for a heart cath. It is definitely an invasive procedure, so we need informed consent by the cardiologist. We also want to do some diagnostic tests. Maybe they got a chest x-ray beforehand, maybe a baseline EKG. They're going to get fluids pre-procedure. It depends on the patient. They might do just standard like 100 mL an hour, or they might base the fluids based on their weight, maybe 3 ml per kilo per hour for the first hour, then 1 ml per kilo per hour. That is usually hung right before they go down. They're going to be NPO. You're also going to assess allergies because they are going to use dye contrast. We want to assess to make sure the patient doesn't have any iodine or shellfish allergies. In that case, if they do have allergies, we usually give Decadron and Pepsid. The Decadron is going to decrease inflammation. The Pepsid is going to be your histamine antagonist. So both of those should prevent or minimize an allergic reaction. And assess their medications as well. We are going to hold certain medications such as Coumadin, Lovenox, Metformin. Metformin we need to hold 24 to 48 hours before and after contrast studies. We can still continue heparin. Typically they just continue it up until they go down to the procedure. They might hold it for a couple hours post-procedure. And the morning of and night before, they're going to do the chlorhexidine or CHG prep as well. Some of the on-call medications, we used to give Valium and Benadryl right when they call and say the patient can be pre-medicated, but now I believe, especially at LG, they wait for the patient to get down to the cath lab, consent them, and then they give the Valium and Benadryl for mild sedation. They also, I've seen a PRN potassium order to maintain good cardiac function. If the potassium is less than a certain amount, we give a supplemental dose of potassium the morning of. We also want to really explain what the patients are going to experience. They might feel palpitations as the catheter is passed through the ventricles. They might feel flush. They might feel hot flashes as the dye is injected. They might feel like they need to cough, and they're going to be under mild sedation. So those are some of the things that we need to tell the patient. Maybe that'll help decrease anxiety, especially if they haven't had this procedure before. So those are all the considerations we need to consider for the patient before cath. And another thing I want to point out is some of their labs. We want to make sure that their BUN creatinine is stable because they're going to give dye, and we want to make sure that the kidneys are healthy enough to be able to handle that extra dye load, to be able to excrete it properly. We also might do a pregnancy test as well. Coagulation studies, they usually won't do a cath if an INR is above a certain amount because of the increased risk of bleeding. And the percutaneous coronary intervention, that is actually when they do a stent. Before the procedure, typically patients receive doses of Plavix or Brilinta and aspirin. If they do have any concerns that or they are expecting that the patient may need a CABG, they might hold some of those doses, especially Plavix. And then during the procedure, they might receive some doses of IV heparin or continuous angiomax, which is a thrombin inhibitor, to maintain an elevated activated clotting time to prevent clotting on the wires and catheters during the procedure. And while a standard PCI procedure uses balloons and stents, sometimes they use something called a rotablation, like a tiny drill that's used to actually remove the calcified deposits, because the regular PCI literally just goes through, they inflate a balloon and actually just compresses the plaque that they find against the wall. So they don't actually get rid of the plaque, they just kind of compress it against the vessel wall. And then they insert the stent to keep the artery open. And the stents they use, you might have heard the terms bare metal stent versus a drug-eluting stent. The drug-eluting stents have medications kind of encoded on them to help prevent that risk of re-occlusion. And usually after stent placement, the patient requires what we call dual antiplatelet therapy. They will probably be on aspirin and Plavix for lifelong. And this is just a picture showing the results of a heart cath. You see that circled area. The dye isn't flowing in that specific area, but after the cath, they were able to see that in the stent that the dye is able to flow through freely through that area. Some of the complications that patients might experience after a cath, worry about having an MI, stroke, bleeding. They might throw a clot. They might have dysrhythmias. They might have reactions to contrast, hematoma at the site, pulmonary edema, hypovolemia. And then specifically, we're looking at pseudoaneurysms at the site. This is a leakage of arterial blood from an artery into the surrounding tissue. Some resolve on their own, others require intervention. It's painful. You can actually see it pulsating, and it is very tender at the site of the catheterization. Usually we're worried really with the femoral sites. And to diagnose it, we use an ultrasound, and to treat it, we use an ultrasound-guided thrombin injection that promotes rapid clot formation. And then we typically do a follow-up scan about 3 to 7 days to determine if that thrombin injection was successful in decreasing that pseudoaneurysm. Patients after heart cath, they're usually on bed rest, depending on what medications they might have used throughout the procedure. The time depends on what they might have used. We like to keep the insertion site extremity, whether it's the radial site or the femoral site, straight. Head of bed, less than or equal to 30 degrees. They're going to be on frequent vital signs. We're really going to assess the site and the dressing for any signs of bleeding, hematoma, or bruise. We do not want to see hematoma or bruise, and we're going to especially assess their pulses, skin temperature, color to assess for perfusion. We're going to encourage fluids to help flush out that dye. We really want to look at their peripheral vascular status. We need to report to the physician if the patient experiences chest pain, neurological changes, dysrhythmia, bleeding, hematoma, or any significant change in peripheral pulses to the affected extremity. We need to report any numbness or tingling, decreased sensation to the affected limb. So those are all signs that we need to call the physician right away. For radial sites, patients might come back with what we call a TR band. It is a radial compression device that they put down in the cath lab to help compress the artery right after they take the catheter out to help prevent bleeding. And essentially they have inflated a balloon over the wrist to help compress the artery, and our role as post-cath care nurses are to determine whether that balloon can be deflated and that band can safely come off. So the balloon and the compression is what's keeping the artery from bleeding out post-cath. So usually the TR band, in report you'll get when the TR band was placed, and the cuff will initially be inflated for about an hour unless they were given things like AngioMax, ReoPro, or Integralin. So let's say the patient went for a heart cath, the band was put on at 9 o'clock. Our first check should be at 10 o'clock. So we're going to use a special syringe, attach it to the balloon there, and slowly take some of the air out that's compressing the artery. And we're going to look for any signs of bleeding as we're slowly deflating the balloon. If there's no signs of bleeding, then we can take the cup off, put a 2x2 on it, put a Tegaderm on it, and just continue to monitor. If we do notice that there's some bleeding while we initially take it off, we can reinflate the balloon using the syringe, just enough to stop the bleeding, and check again in 30 minutes. So you can do that, and you can do that times 2. So let's say you try to check it at 10 o'clock. It's still not ready to come off because it started to bleed. You reinflate it, you check it again at 10:30. It's still not okay, so you can check it at 11 again. So you can repeat that times 2. So the total compression time, if they didn't receive any additional medication, should be 2 hours. It shouldn't go on for more than 2 total hours because you can recheck it times 2. And then after you take it off, once you're at that 2-hour mark, you're just going to have to take it off, and you might have to use manual pressure. And I've had instances where I've literally sat on the patient's bed holding my hands on that artery to get that to stop bleeding. But if you really experience any complications, you can just call down to the cath lab staff. They'll send someone to help you with minimizing the bleeding. They'll probably come up with some topical hemostatics, special foam and dressings that actually will help to help the bleeding clot, and they might use special patches that promote platelet activation and speeds up hemostasis. But your role is to really check to see if the TR band is ready to come off. Post-cath patient teaching, certainly talks to them about risk factor modification, diet, exercise. Afterwards, they might need some activity limitation. They might not be able to drive for 24 hours. The dressing needs to stay in place at least for the first 24 hours. You're going to tell them to avoid lifting and other strenuous activities, and tell them to observe the insertion site over the next several weeks for swelling, redness, warmth, and pain. A little bit of bruising is expected, but tell them to keep an eye out for any signs and symptoms of bleeding, infection, things like that. And just going over some of the medications. Anti-lipemics, they either lower LDLs, which is your bad cholesterol, increase LDLs, we want high HDLs that help promote the cholesterol back to the liver, and or decrease overall cholesterol and triglycerides. And we see statins, cholesterol absorption inhibitors, bile acid sequestrants, nicotinic acid, or fibrates. For all of those, you need to obtain baseline lipids, liver and kidney function tests, so AST, ALT, and monitor them periodically. We're going to basically talk about the HMG-CoA reductase inhibitors for the purposes of this voiceover, or your statins, which I'm sure a lot of you have given already. Simvastatin, pravastatin, or they might be a combination. They interfere with this enzyme, HMG-CoA reductase, that essentially is responsible for cholesterol synthesis. So you're preventing that enzyme from making cholesterol. It decreases LDL and increase HDL and decrease triglycerides and your total cholesterol. Adverse effects, hepatotoxicity, so monitor AST, ALT. One of the unique side effects is myopathy. They might have muscle pain, muscle weakness. And we usually like to give it in the evening because that's when your body actually makes cholesterol and you have some of your interactions there. And then certainly go over some of the other classes, but I'm just going to skip over them for now and move right along to MONA. acute coronary syndrome treatments are priorities. So you might have heard of the acronym MONA: morphine, oxygen, nitroglycerin, and aspirin. Along with those medications, we want to give oxygen in someone with chest pain, get them in a semi-Fowler's position, and help to promote a calm environment to help reduce anxiety. First up is morphine. It is an opioid analgesic that binds to opioid receptors in the CNS to produce analgesia. For the purposes of chest pain, it helps relieve anxiety, it decreases myocardial oxygen demand, it relaxes smooth muscles, and decreases catecholamines. Some of your safety parameters are looking for a respiratory rate, because it can cause respiratory depression, it can cause hypotension, bradycardia, and level of consciousness. And our antidote for this opioid analgesic is your Narcan. O is for oxygen. Remember, in someone with chest pain or angina, you have that imbalance between oxygen supply and demand, so you want to increase that availability of oxygen to your myocardium. We usually start at 2 to 4 liters per minute on nasal cannula to titrate to maintain oxygen sats above 95. We might need to encourage that deep breathing to increase oxygenation. N is for nitroglycerin or nitro. It is a nitrate that is a vasodilator, relaxing your vascular smooth muscles. It can help with angina. It can also decrease your blood pressure. Again, it's a vasodilator to increase blood flow and dilate your arteries. So it decreases preload and afterload. One of the most important things to consider is hypotension. It can drastically drop your blood pressure. So we need to assess that before we give nitro. It comes in sublingual and spray. For the sublingual, you can do 1 tablet of 0.4 milligrams every 5 minutes, up to 3 doses over a 15-minute time period. Again, assessing for hypotension. Because of the vasodilation effect, it can also cause a nasty, nasty headache, which patients might complain of. So because of the risk for hypotension, have them lay down, monitor for blood pressure, and make sure they put it under their tongue so it dissolves. And we want to make sure that they haven't had any phosphodiesterase inhibitors for erectile dysfunction, because that can really cause that additive hypotensive effect. For patients that you're educating at home, tell them to call 911 if the chest pain is not relieved after the first dose. That should be effective within the first 5 minutes. And as far as also additional patient teaching, for nitroglycerin tablets, make sure that you tell them to store it away from heat, sunlight, and moisture, making sure they don't just store it in their pockets or their glove boxes in their cars, and make sure that they have recent prescription, because sublingual nitro shelf life is only about 6 months, so they need to replace it every 3 to 5 months. So those are some important education points for nitro. And it kind of does come in like a darkened bottle to remind you to not store it, to store it away from sunlight. So those are some things that you need to tell your patients. Some patients with unrelieved chest pain, they might be on a continuous nitro drip, and that can be titrated per protocol, starting at 5 micrograms per minute. And then you can slowly increase it until they're chest pain free. They usually need to be in II or ICU for this. Again, checking blood pressure, chest pain level frequently. And once they're stabilized, they might be able to switch over to oral or topical. And when we talk about long-term nitrotherapy, in order to prevent tolerance, we do what we call an 8 to 12 hour nitrate-free period. So especially for some things like your transdermal patches, we do like an on for 12, off for 12 to prevent tolerance. So we don't want long-term maintenance. We don't want them to be on it continuously, so they don't develop a tolerance for it. Transdermal patch can come in. Transdermal, it can come in an ointment or patch using on a non-hairy area of the body. For the ointment, you're going to apply the correct amount on a dose measuring paper. It's going to say like an inch, half an inch, and use a special paper to put the ointment on to measure the exact dose, and then you're going to place the paper with the ointment on hairless area of the body. And the patch, you need to remember to remove the old patch prior to applying the new patch. And again, removing the patch after approximately 12 hours each day to prevent that nitro tolerance. And remove any residue from the previous sites. Remember to rotate it and don't touch it with your bare hands. And last acronym A for Mona is your aspirin. We went over this last semester, but it has a couple different classifications. It's an antiplatelet because it decreases the aggregation of platelets by blocking that thromboxane A2 receptors on your platelets. It's also a salicylate. It's an antipyretic for fever, anti-inflammatory by blocking cyclooxygenase that's needed for prostaglandin synthesis. And remember that prostaglandins are important mediators in the inflammatory response. And the dose is usually 81 to 325 for patients with CAD, history of MI. And when someone has new onset of angina at home, we usually tell them to take a full dose, 325, or chew 4 baby aspirins and call 911. And some of the side effects are GI upset, so we should tell them to take it with food, risk for bleeding, and tinnitus can indicate toxicity. And we won't talk about antiplatelets, beta blockers, ACEs, calcium channel blockers, and fibrinolytics. Please review some of the PowerPoints from our anticoagulant lecture for more refresher. But I just want to talk about the MONA acronym. And then long-term medical therapy, they might be on warfarin or Coumadin, aspirin, Plavix. Again, the aspirin and Plavix, they might be on both as dual antiplatelet therapy. Beta blockers are going to help, statins, and ACE inhibitors and ARBs. So please make sure you review some of the other classes. Patient education. We, again, want to talk about risk factor modification, diet, exercise, smoking. Educate on signs and symptoms of an MI. Remember, women might present differently. They might have more fatigue, GI symptoms. The elderly are going to present differently. They might initially have a lot of confusion. If on nitroglycerin, teach nitro uses. Patients with stable angina, they might be taught to carry nitroglycerin and take it before any strenuous activity for preventative measures. Teaching about needing recent prescriptions, needing to store it away from light, and that they can take up to 3 doses within a 15-minute time period. Again, cardiac medications, why they're on them, why they might be on both a beta blocker and a calcium channel blockers, and how they work. So make sure you look over some of the mechanisms of actions on those. And teaching about any diagnostic tests, why they might go for a stress test, or what to expect during a cardiac cath. Assessments. We're going to look at vital signs and symptoms of CHF. We're really assessing tissue perfusion. And assessing functional ability, we're really assessing activity tolerance. Can they do LDLs? Can they do their household chores? And when they're able to return to work or maybe resume sexual activity, that might be a concern for some patients. Again, teaching about lifestyle modification, nutritional status, and how understanding of illness and treatment, how to treat angina, when to call their healthcare provider, medication, education, how they can advance and when to limit activity, and how they can modify risk factors. Just real quick on cardiac rehab, it is a medically supervised program that helps improve the health and well-being of people who have cardiac issues. They're available in home care, nursing homes, transitional care, and outpatient centers that include exercise training, education on heart, healthy living, and they might also provide counseling to reduce stress and help you return to an active life. During cardiac rehab, when they're exercising, they like to check vital signs with each increased activity. They monitor for changes of 20 beats per minute in heart rate and any changes in blood pressure by 20 points, as well as shortness of breath or chest pain. That indicates tolerance or activity. So if they do experience any of those vital signs changes, that's when they know that they need to stop that activity, and they shouldn't move forward. That's their limit. They also talk about isotonic exercises versus isometric. We want to encourage isotonic exercises, that where the muscle remains a constant tension as it moves. So swimming, walking, jogging. Think aerobic exercises. We want to avoid isometric exercises such as weightlifting, any thing that does pulling or pushing, where the muscle remains constant as the tension is increased. So we want to encourage isotonic aerobic exercises, avoiding isometric exercises. And so candidates for cardiac rehab, anyone that's had an MI, stents, cabbage, they usually can begin rehab about a week after an uncomplicated MI. We focus on what they can do. We establish mutual goals, again with those isotonic exercises, those aerobic exercises that doesn't cause any lifting, pulling, pushing, straining. Educate on lifestyle changes. And we need to be cautious with patients that have unstable angina, arrhythmias, severe COPD. And again, we know that we can push these patients to do those exercises, but we need to stop the rehab or exercise if their heart rate or blood pressure goes about 20 points above or below their baseline, or if they develop chest pain, shortness of breath.
Hey, Mom, look at me. Mommy.
And what are some of your priority nursing diagnoses? Acute pain is your priority, so managing that chest pain. They might be in denial. They are going to have altered tissue perfusion because of the decreased oxygenation. They might have a knowledge deficit as to what happened and how they can take care of themselves. And psychosocial would be anxiety. They're really going to be anxious. They don't want some of these events to happen again. They're going to want to get extra support. So those are your priority nursing diagnoses. And that wraps up our CAD treatment. Certainly reach out to me or use the discussion board for any questions.